Okay, well, welcome everyone. Thank you for coming. It's a pleasure for me to introduce Mecole Rothman to you. Mecole is an associate professor of medicine in our division of endocrinology. She has a very unusual past, and I want to emphasize that I've looked at literally hundreds of CVs, and in medicine, I haven't ever come across anyone who's majored in Latin as an undergraduate. But Mecole has majored in Latin as an undergraduate, and maybe she'll educate us about that as part of her talk. She went to Brown University and graduated with honors, and then went on seamlessly to an MD degree at Columbia University. She did her house staff training at Hopkins and served on the Osler service, and then we recruited her here into the endocrinology fellowship program, and she stayed here ever since. She did research with Maggie Wehrman on sex hormones as they affected a variety of different outcomes. But then decided to focus on osteoporosis and has become both a clinical expert in osteoporosis and has led a number of clinical trials in osteoporosis. So it's a pleasure to introduce our Latin scholar, Mecole Rothman. Please give her a round of applause.
Thank you, Dr. Schwartz. The entire lecture will be conducted in Latin. There'll be a test afterwards. So I'm really excited to be here today because this is a topic near and dear to my heart, as most of you know, many of you know. And there's a lot to be said, I think, from an inpatient and an outpatient perspective. So it's nice to have the full gamut of people here with both of those focuses. I have no disclosures. So what I really want to bring home today is that there is a crisis in the treatment of osteoporosis right now, and we're going to talk about why that is and all the different factors and what we can do going forward. So this is hopefully not going to be a depressing talk, but hopefully give you some sense that there is some light coming. A lot of the referrals that we get in the metabolic bone clinic from primary care are really about osteoporosis medicines. Who do we start? Who do we stop? How long do we treat? So I want to make sure we address some of that as well. And then I want to talk about some of our recent inpatient efforts, because this is kind of a new thing that even some of our endocrine folks may not know about, and talk about our fracture liaison service and some of the hip fracture protocols that are in place that I think are really exciting in this area. So I want to start with a case. So this may not happen anymore, but when I was a resident, let's say, you may have been called down to see a 78-year-old man who fell out of bed in the middle of the night, tripped on his way to the bathroom, and had a left femur fracture. So again, I'm sure this never happens now, but what used to happen is that the medical resident would get called, and they would say, no, you really need to call ortho. So the ortho resident would get called, and then they would find out that the man had a history of coronary disease. So at that point, they would say, well, the patient really should go to cardiology. And then the cardiology fellow would get called, probably pretty unhappy in the middle of the night, although they probably get called in the middle of the night more than the endocrine fellows do, I suppose. But the cardiology fellow would get called and say, no, really, this patient has a normal EKG and a negative troponin, and we really think that it's okay. So this would kind of go on for a while, and then eventually the patient will go to medicine, generally, because we tend to be the path of least resistance, I think, still. And then gets taken to surgery the next day. So after he gets taken to surgery, the surgery goes well, but he gets pain medication afterwards and becomes delirious, which extends his hospital stay for a couple of days. At which point he eventually does get discharged and goes to a SNF and comes back to primary care. And at the primary care visit, his spouse is there. She's very overwhelmed. He hasn't returned to his level of previous functioning. And much of that visit is spent just talking about all the things that they're doing and all of his medications. And it kind of goes from there and how overwhelmed that she is. So he goes on, and unfortunately, the next year falls and breaks his other hip. So those things do happen. And what happens here is that the osteoporosis often gets lost in the shuffle of everything else that's going on. So why does this happen, and how can we do better? So I want to touch a little bit on the basics here. So recall a little bit of your bone biology, that we are all turning over our skeletons constantly. And that starts with resorption from osteoclasts. Remember, they're going to dig out their caves here, and you're going to fill in nice new osteoblasts. And that's a small percentage of your bone cells. And then a cell that we don't often focus as much on, I think, clinically, but certainly a lot of our researchers do, is we also have these cells called osteocytes, which are responsible for secretion of many factors and some new drug targets, and are also responsible for weight loading. So when we say do weight-bearing exercise for osteoporosis, these are the cells that like being knocked around, and they'll then send out signals to osteoblasts to form new bone. So we're constantly going through this cycle of turning over our skeletons. Over the course of the lifespan, we tend to be in a phase of where we're really, putting down, forming a lot of new bones. So you can think of this as osteoblasts, bone formation, osteoclasts, bone resorption. Things are really, happening here around puberty and growth spurts. And then this slide is for women. It really should settle out over the premenopausal years. And then around menopause, there's an uptick in resorption. And most of the drugs that we use tend to be anti-resorptives. We'll talk about anti-resorptives versus anabolics. And then things kind of quiet down a little bit again. But this uptick in resorption is what's thought to be responsible for generally most menopausal bone loss. And when you think about the drugs that we have, and we'll go into more detail about them later, our drugs are either focused on bone formation, so we now actually have 2 anabolics on the market, teriparatide and abaloparatide, or on bone resorption. And this is where estrogens and SERMs act, this is how bisphosphonates act, and this is how our rank ligand inhibitor denosumab acts. So why is there a crisis in the treatment of osteoporosis? So this is from a group from the ASBMR a couple of years ago, where they literally made a fracture bound of casts. And this was a group called 2 Million Too Many. And they were talking about the fact that 2 million fractures occur in the U.S. each year, and that there is really this crisis in terms of the treatment of osteoporosis. About 50% of women will have an osteoporotic fracture, and the mortality after hip fracture is about 20% and higher in men than in women. And it is one of these areas where men are often the ones who are getting undertreated for their osteoporosis. Only about 40% of patients with hip fracture fully regain their pre-fracture level of independence. And the story I discussed with our patient is a very typical story of patients losing independence, often going to rehabilitation and never regaining that pre-fracture level of independence and function that they had. And we worry about fractures because we know that fractures predict fractures. So even vertebral fractures will predict future fractures. Sometimes we'll see an incidental compression fracture noted on a chest X-ray or maybe not noted on a chest X-ray. But even some of those silent fractures can still predict future fractures. And again, this is an area where we really don't do well. So you'll say, well, this is an old slide from 2002, but look at the rates of treatment after fracture. So here, only 4% of men being treated after fracture. And here, the medications were a little different. We were using more estrogen then and maybe more calcitonin. But again, still here, only about a quarter of women being treated. So you'll say, oh, that was 2002. Well, unfortunately, we are not doing better. We're actually doing worse. So overall, medication use after hip fracture is trending down. So this is a study that looked at rates of medication being initiated after fracture in the first 12 months. And you'll see that, here's some of these rates that we talked about, around 30%, 40% back in 2002, and it's actually steadily getting worse. So what's going on? We have medications. We know more about what's causing fracture. We're trying to raise awareness. Why are we doing worse in terms of hip fracture treatment? So I would argue that it's multifactorial, and I want to focus on a few of these. So screening rates in general are still suboptimal, and we'll talk about that. There's this lack of recognition, like the case I pointed out, that fractures are associated with osteoporosis. So if I fell right here on this stage and broke my hip, that's not normal. And honestly, if there's one thing that you can take home from this lecture today, just remember that you really shouldn't break a bone falling from a standing height. And we get wrapped up in the hospital in terms of other things that are happening and other things going on with patients, but that is not normal. So there's that lack of recognition. And then I think this is what's happened more recently, too, is this has been compounded by the fears of osteoporosis medications. And there's a lot of unknowns out there, like I said, of what to treat, how long, who to treat with, things in the media, and we'll talk about that as well. And then what happens with the initial fracture, as in my case with the elderly man with the left hip fracture and subsequent right hip fracture, is that we often don't streamline care for those initial fractures, and that's what leads to these secondary fractures. So let's talk a little bit about screening rates. So I borrowed this slide from Michael Lewicki, who's a well-known bone researcher in New Mexico. And this was a really compelling study that he presented last year at the ASBMR. And you'll see that he pointed out here that there's been a trend in DEXA reimbursement. So DEXA reimbursement, there's been a couple of times where it's kind of gotten a little bump up in Congress for various reasons, but it's pretty much steadily decreased over the last 10 years. And what he showed is that with that decrease, there was kind of an initial bump in DEXA testing, but then it went down. And that with that, of course, the actual diagnosis of osteoporosis is going down. And what he did is he coupled this with hip fracture rates. And hip fracture rates had actually been steadily decreasing for a while, but then have really started to level off, whereas the projected is that they really should still be coming down, but they're leveling off. And he really makes this argument that are all these things coming together, and we're actually now starting to see a leveling off of hip fracture rates, and maybe we're going to even see them go up if we don't do something about this. So we hear a lot about over-testing, and DEXA was one of those things, I think, in Choose Wisely, where we worry a lot about over-testing, and you always hear about, this group of people, and oh my gosh, 6 years went by, and they're getting 4 and 5 and 6 DEXA tests. I would argue to you that the problem is truly still more this group. So yes, there are a small percentage of people who are being over-tested, but there are still a large percent of women who never get a screening test at all. So this is women, 65 and up, who are just not even getting a single bone density. So concerns more for under-testing truly than over-testing. And I actually, thanks to our ambulatory health promotion group, Alexandra Marcus working with Lisa Schilling's group, I have our data, and I'm happy to share with you that we are doing better as an institution than what I just showed you. And overall, we looked at, in EPIC, we looked at both women getting their DEXA here and anything that had been scanned in and inputted into the health maintenance module. So this may still, in fact, be a little bit of an underestimate, depending if you're not using the health maintenance module. But you can see here by group that overall we're getting, this is one-time DEXA, women 65 and up, not a group that everyone agrees universally should be screened. We're getting about 72%, and it varies a little bit over some different practices. But overall, we are doing better. But still, again, women 65 and up, that's a group we should really be capturing. So what about this lack of recognition of fractures being associated with osteoporosis? So how many times have you heard these things from your patients, right? So it was really icy out there, I fell really hard, I just tripped. So again, this is osteoporosis. This is not a normal bone breaking from standing height. So this is a recent survey, and this is women post-fracture, 634 women who actually had fracture, who had contact with their PCP post-fracture, and 73% of them indicated that their PCP knew about the fracture. So 63% of them had osteoporosis management discussed, 55% had fracture prevention discussed, 31% still said the main source of their osteoporosis information was the media. And only less than 20% actually thought that osteoporosis caused their fracture. So these conversations are starting, but they're still not leading to enough medication, treatment, people truly connecting the fall with the fracture, or the fall with osteoporosis. So let's talk about the fears. This is often kind of the big thing. When I give talks on osteoporosis, I find that unfortunately, we end up spending more time than we would like talking about this, but we need to talk about it because even though we see a lot of these events as rare, this is often what our patients are really wanting to talk about. So we have a lot of good medications out there, and I want to talk about some of the good before I talk about some of the concerns about side effects. So again, we have our oral bisphosphonates, widely available, low cost, some rare but serious side effects that we'll talk about. We have our IV bisphosphonates, convenient, avoiding some of the oral side effects. We now have denosumab, our rank ligand inhibitor, subcutaneous injection every 6 months, doesn't need to be adjusted for renal issues. We have teriparatide, our anabolic, and we now have another anabolic pretty similar. This is an analog of PTHRP instead of PTH that came out in May, got approved in May. Pretty similar side effect profile. So we have good medications, but there seems to be a lot of confusion still on who to use them on and how long to use them, etc. So I want to start with the good. Oral bisphosphonates are good medications. They're low cost, they're widely available, and they reduce fractures. So they reduce vertebral fractures, they reduce hip fractures, they reduce non-vertebral fractures. They may even have some other effects in breast cancer risk, skeletal metastases, maybe even decrease mortality. So these are overall really good drugs that do seem to get a lot of a bad rap. The IV medications that we have, so we don't have a lot of data on osteoporosis in men, but we do have the 5 milligram IV zoledronic acid trial that actually looked at mortality. So when you look at these numbers, decreases in fracture, but also decreases in mortality that even went beyond the fracture decreases. So there were really some thoughts after this paper came out that maybe there's even some non-bone side effects of bisphosphonates that could be decreasing mortality. And this was actually a trial that included men. But what do you hear from your patients, right? So then it's like, all right, I don't know, send this patient to metabolic bone clinic and then see if they can talk them into taking medication, right? So this is what we're hearing from patients. We're hearing about atypical fractures and jaw necrosis and all that. What do you say to patients? So osteonecrosis of the jaw, what is it? First of all, it's a horrible name, right? I mean, it sounds awful, and it can be awful for people who experience it. But the name it certainly causes a lot of fear in patients too. So this is exposed necrotic bone in the maxillofacial region that doesn't heal after 6 to 8 weeks. So this is usually after an extraction or an invasive procedure. You'll have exposed bone that doesn't get better. These are rare. So this is the most recent ASBMR task force, and you can see that it is a little different. So oral bisphosphonates are the most rare, then more with IV. It certainly has been reported with denosumab. So denosumab is an anti-resorptive. The same side effects can be seen with denosumab as with the bisphosphonates. In the oncology patients, the estimates are higher. So these are patients who are often receiving higher doses more frequently and have probably other risk factors, and there are more concerns with oncology patients. There are other risk factors besides just oral bisphosphonates. So these are things that you want to ask your patients about. So patients who are also on glucocorticoids, patient with poor oral hygiene to start with, patients with dentures that don't fit well are a risk factor, and diabetes as well. A lot of times the dentist will ask you to draw a serum CTX. That's a marker of bone turnover, and we get that question a lot. What is this? What am I supposed to do with this? How do I interpret it? So CTX is a marker of osteoclast function. You can think of it that way. So when CTX is low, you are suppressing bone turnover, and generally what we think of it as is that your medication is working. It has not been shown to predict osteonecrosis of the jaw. It predicts that your patient is taking and absorbing their bisphosphonate and it's working. But there's been a lot of requests sometimes from dentists to see if their patient has a suppressed CTX, that perhaps they're therefore higher risk for osteonecrosis of the jaw. We do ask patients to try to get a dental exam and get their teeth extracted, et cetera, before starting treatment, if that's an option. And really trying to communicate with the dental colleagues, I think, is important. And again, a lot of these are in conjunction. These are from also the American Dental Association guidelines. So there has been time that I've actually taken these guidelines and faxed them over to the dentist and said, we really don't need to draw a CTX. But you really do have to try to work with your dental colleagues and see if you can get an agreement about what to do with the drug, when to start, if to hold, etc. And there's a lot of confusion about there too. Remember, teriparatide and our anabolic medications are not associated with osteonecrosis of the jaw. And I've had dentists who will hold that medication when they're doing extractions and stuff too. So there's just a lot of confusion out there about what these medications are and how they work. So atypical femoral fractures, again, very dramatic. This first came to attention in about 2007, 2008. And what this is the reason why it's an atypical fracture is that a typical hip fracture, right, is going to happen up here, and generally a femoral neck fracture or something like that. These are atypical fractures because they're happening in the subtrochanteric region here. And the classic story that you hear is that basically someone's walking and they break. So it tends to be that the bone seems to break and then a fall versus a fall and then a break. And there's often a prodrome. So if you kind of look back with the patients, there'll have been some thigh pain that's happened for a while. And oftentimes it can be on both sides as well. So these are frequently bilateral. And there are criteria for these that they are often, they do kind of have this angle and they have these thickened cortices and that they are often bilateral as well. See here the thickened cortices. So these are the typical findings of an atypical fracture, if you will. So how often are these happening? So it still remains unclear exactly how common these are. And it's a little hard to go back sometimes because you really have to have the x-rays to know if these are truly meeting the criteria for atypical fractures. But with that, the most recent estimates are about 3 to 50 cases per 100,000 patient years. The risk does seem to go up with longer use and does seem to decline once the drugs are stopped. So this is where we start to get into the whole drug holiday notion. And some of that comes from this ASBMR task force report as well, where you can see that the rates with 2-year exposure are lower than the rates with much longer exposure. So that's where some of those concerns come up. When I talk to patients about this, I try to weigh their individual risk of fracture, and we'll talk about FRAX and some of those other things in a bit, with their risk of an atypical fracture. I mean, notoriously, as a society, we're really bad about thinking about risk, right? Like we don't do things like wear seatbelts, and we drive our cars, but yet we worry about, things that are very rare and unlikely to happen. So it's often just really difficult to think about risk. But in general, the people that you are suggesting take an osteoporosis medication are going to have a risk of a fracture of about 20, 30% over the next 10 years. And they're going to have a very low risk of having an atypical fracture. So I try to kind of weigh that individual risk for that patient. That said, if a patient on bisphosphonates or denosumab complains of thigh pain, I'd absolutely take that seriously. So, and by seriously, I mean investigating with films. We have certainly caught some of these early and been able to treat them with anabolic medication. We've been able to rod them prophylactically. So if you hear about thigh pain, absolutely take it seriously and image it, because you certainly can catch things before they become complete fractures. And then thinking about the risks and benefits of long-term treatment, and we'll talk about that a little bit more. So I think what also happens with medications is guidelines, creating an awful lot of confusion. So I think that it can be very difficult in primary care and in specialties when you have all of these competing guidelines. So I want to talk a little bit about the new ACP guidelines, because I think that they have also contributed to this confusion, honestly. As well, and then you have competing guidelines from the National Osteoporosis Foundation and then the endocrine groups as well, and I think it can be very difficult to try to sort through all of this and figure out what to do for your individual patient. So the NOF guidelines I'm going to talk a little bit about first. Those came out earlier, and that was the first time we had guidelines related to FRAX. So the NOF guidelines, I think, are pretty straightforward, treating postmenopausal women, or men over 50, who have had a hip or vertebral fracture. Again, getting back to that notion, low trauma, hip or vertebral fracture equals osteoporosis. They do also suggest treating those with a T-score of less than minus 2.5 with no other risk factors. There are certainly occasions where you will see a patient who you deem is quite low risk, who still meets that criteria and may not need treatment, but certainly someone to think about it. And then in this osteopenia range, they gave us this guidance of looking at FRAX. So again, you're going to treat them if they've had other fractures. You're going to treat people with secondary causes, perhaps aromatase inhibitors, glucocorticoids, those kinds of things. And then that's where this FRAX guideline came from, of a 10-year fracture risk of more than 3% at the hip or more than 20% for a major osteoporotic fracture. So let's just look at FRAX a little bit and think about how we have to think about more than the T-score. So this is FRAX with its website. So if you put in a 65-year-old woman who's gotten her screening study, she has a T-score of minus 2.3, and she has no other risk factors, her major osteoporotic fracture risk is going to be here is less than 20, and her hip fracture risk is less than 3. However, you really have to look at more than just the T-score. So this is going to change if she's someone who has more risk factors, right? So if it turns out that she had a parent with a hip fracture and she's a current tobacco user, that's going to alter things. Age also matters a lot. Age is a very important independent fracture risk. So a 65-year-old woman with minus 2.3 is different than a 75-year-old woman with minus 2.3. So I think FRAX can be helpful, and I'll sometimes use it live with the patient to really put all of this together. So a T-score of minus 2.3 in and of itself isn't meaningful. You really need to look at the patient and their risk factors. So it's not all just about the T-score. So again, back to the guidelines creating confusion. So there was a lot of unhappy metabolic bone and endocrinology folks, I will tell you, when these ACP guidelines came out. And I'm guessing some of you are probably familiar with them. And I'll tell you, I'm not even going to go into the DEXA part today. That could be a topic for another day. But this is just truly to talk about the medication part. So they recommended that patients be treated with alendronate, risedronate, zoledronic acid, or denosumab to reduce the risk for hip or vertebral fractures. And I'll show you where that came from in a minute. And then just this blanket statement, recommend that clinicians treat osteoporotic women with pharmacologic therapy for 5 years. Blanket statement, not which drug, not which women, not with which risk factors, just a blanket statement. And I think that was a real mistake. So where did it come from? It came from here. So I know that there was a goal at the ACP to really try to make things, primary care has all these competing guidelines. We really have to make it straightforward, something that everyone can follow. But unfortunately, I really don't think that they succeeded in that because I think it's really just created more confusion. So it comes from here. It comes from the fact that the drugs that have hip fracture data are alendronate, risedronate, zoledronic acid, and denosumab. Abandronate, as I showed you previously, doesn't. Raloxifene doesn't, and our anabolics don't. However, they do have other fracture efficacy, and there is certainly a role for some of these other drugs. So when we look at our anabolics, for example, they have a completely different profile than our medications for osteoporosis. So we know that our anabolic medications can raise spine bone mineral density more than a lot of our anti-resorptives. We also know if we give an anabolic agent first and then follow it up with an anti-resorptive, we can do a lot better by the patient than if we give an anti-resorptive first. We often blunt that anabolic response. So one of the most potent things that we can do is give an anabolic first and then follow it up with an anti-resorptive therapy. And this is just showing you that teriparatide is different than a bisphosphonate. So in the initial group here that got parathyroid hormone followed by placebo, they gain and then they lose what they gained. And the combination group was over here, and you see that the most potent thing that you could do here is parathyroid hormone followed by alendronate, but certainly not followed by nothing. So if you were to treat someone with anabolic therapy, you absolutely have to follow it up for something, and you're not going to necessarily just follow it up for 3 years. You may want to follow it up more. You may want to follow it up less. It's going to depend on your individual patient. So just saying all patients should be treated for 5 years, there's not really any sense in that, and you have to think about the medication. If this patient had already had some bisphosphonate and then you gave them teriparatide, you're not going to not follow it up with anything. So I think it's just really created a lot of confusion. So not all of these drugs are the same. When teriparatide is stopped, you're going to lose the efficacy from it. And that's different than a bisphosphonate. So it really depends on the type. So the bisphosphonates are different. So this is a trial that's showing the onset and offset. This is a paper that reviews a trial that shows the onset and offset of zoledronic acid versus denosumab. So zoledronic acid stays in the bone for a long time. That's why you can give it once a year. So this is looking at people who got zoledronic acid for 3 years, followed by placebo for 3 years, versus zoledronic acid for 6 years. The differences are very small. There's a small group that benefits who's very high risk, who has clinical fractures up front. But for the most part, people can receive zoledronic acid for 3 years and then nothing for 3 years. The follow-up study of that looked at 6 versus 9 really didn't show any benefit. So we probably shouldn't be treating anyone with zoledronic acid for more than 6 years in a row. But this is different than denosumab. So this is one of the original denosumab trials that was looking at different dosing. But you can see here, this is markers of bone turnover. So when you stop denosumab, bone turnover markers go up robustly. And in fact, there's been reports of vertebral fractures happening quickly after cessation of denosumab. So we get this question a lot, oh, this patient's been on denosumab for 5 years, should we stop it? So it's not a bisphosphonate. The pharmacokinetics are not the same. And I really have concern with that message of saying stop everything at 5 years because you can get rebound vertebral fractures and really get your patient in a lot of trouble. So these medications are not the same. So where did this drug holiday come from? So these are the group of people that you can think about stopping for after 5 years. So FLEX was a study that followed up of a trial called FIT, where they basically had women on alendronate for 5 years, and then some of the women stayed on for 10, and some of the women went off. And there's a lot of this, you may remember, came from this question of how long should people stay on. So we've all been trying to figure out who are the group of people who might benefit from staying on for 10 years. And that's what a lot of the looking back at this trial was trying to answer. So the women who probably benefit the most are the women who are the worst off at the end of the 5 years. So if you were on bisphosphonate for 5 years, and at the end of those 5 years, you still had a T-score of less than minus 2.5, or you had a vertebral fracture, you have to treat very few women to benefit. So this is a group of women you might consider for treating for 10 years. However, if you had someone who is greater than minus 2 and did not have a fracture, well, they're ones who are probably not going to benefit from ongoing bisphosphonate therapy. And this is where this idea of a drug holiday and really kind of starting to risk stratify women better into who's going to benefit from long-term treatment versus who isn't. So again, to get back to this recommendation, I would argue that instead of saying 5 years, this is from that New England Journal, an editorial in the same journal I just showed you. So if you have a T-score of less than minus 2.5 and you've had vertebral fractures, you may benefit from more than 3 to 5 years of bisphosphonate therapy. If you've been on for 5 years and you have a T-score that's better than minus 2 and you haven't fractured, you're probably not going to get any ongoing benefit. And some of those women, honestly, were people you might not have started in the first place if you kind of knew then what you know now. But those are people you can probably stop for a while and reassess. But again, this does not apply to denosumab, where there's data now out for 10 years of continuous use, and this certainly does not apply to anabolic therapy, which has to be followed up with something else. So the medications are different. So lastly, I want to talk a little bit more about efforts here in terms of trying to streamline our care for fracture patients. So what's happening here? So remember the 78-year-old guy with the hip fracture? So 3 or 4 years ago now, UCH implemented a comprehensive hip fracture care program. And I want to give a shout out to Mary Anderson Wallace, Jason Stoneback, and Kelly McDevitt, who had an IHQSE project on this and really worked to streamline all aspects of hip fracture care, not just the osteoporosis part. So instead of having all those fights on the phone now between the ortho and the cardiology and all of that, all patients go to orthopedics. All patients have a medicine consult. There's order sets in place for pre- and post-op management, and this is not just osteoporosis. This is DVT, this is pain control, this is trying to reduce delirium, all of those things. From an osteoporosis standpoint, basic labs are drawn, and a bisphosphonate is initiated in the hospital at the time of discharge if there's no contraindication. So this is what Mary and her colleagues published after this, and the results were great. So they actually reduced length of stay. And in terms of the metabolic bone, they really got a lot of people on osteoporosis medication and on calcium and vitamin D at the time of discharge. And you can see here patients were following up more with PCP, as well as metabolic bone, as well as orthopedics. So this was a group that they had looked at, obviously, before the intervention started and then afterwards. So what happened after that? We were able to follow up a small subgroup of these original cohorts. And again, this is small, so take into account that the ends are small, and we just looked at this and submitted this for Endocrine Society. So we only have 36 people in our pre-fracture group, pre-intervention group, and 38 people in our post group, and you can see that the rates have definitely dwindled over the course of the year. So there is, these were not significant, but there is sort of a trend towards more people being on osteoporosis therapy after intervention, but clearly there's some loss, there's some attrition there between the discharge and the one-year follow-up. So what do we do about that? So nationally, internationally now, there's been a lot of work on fracture liaison services. And this is kind of just a big topic in general. It's nothing unique to University of Colorado. But the idea is that you use a team to identify patients who have fractured or at high risk for fracture and institute therapy to prevent secondary fractures. So there's 2 studies that I'll show you. Basically, there's lots of different ways that you can do this. So there's ranging from an A-type FLS is basically the most interventional. So basically the fracture liaison coordinator reaches out, starts the patient then and there on a bisphosphonate, kind of calls them, nags them, follow up. B is kind of a little bit less, like the coordinator will reach out and make a PCP appointment, suggest follow up. And C and D are kind of more just kind of reaching out and bringing awareness to the patient, but not initiating therapy. So there seems to be a trend that is probably more successful the more kind of interventionalist that you are. But you can see across the board that these fracture liaison services are really improving bisphosphonate use. They're improving fracture rates, and I'll actually show you a study that shows that a little bit better. But the idea is that, really making that connection right after the fracture in an ongoing way. Maybe you can improve those one-year fracture rates as well. So this is a study that looked over 3 years at this is not in the U.S., but it was 515 patients who had a hospital that had a fracture liaison services, whereas 416 patients who didn't. And you can see that there were more fractures at the non-FLS hospital over the course of 3 years. And they really showed reductions in major refracture rate in the FLS patients compared to the non. So there's really thoughts that an FLS can improve fracture rates post initial fracture and in an ongoing way. So what are we doing? So we have now started a fracture liaison service here in 2017. And some of you in primary care have heard us come around and talk about it, and thank you for letting us take care of your patients. But through a lot of our ambulatory health promotion team, we are now screening any patient who's admitted to University Hospital or who is seen in the emergency room with a low trauma fracture who has one of our PCPs as their primary provider. And we are then setting up a primary care appointment, doing basic laboratory testing, doing a DEXA if not within the last 2 years, and then setting up a primary care visit just to focus on osteoporosis, with the idea being that it hopefully won't get lost in the shuffle of all of the other things going on, and following up with the patient and really ensuring that that has happened. We have some folks working from the pharmacy team as well to ensure that the bisphosphonate is actually getting picked up. Is it getting taken? Do they have questions about it? And really trying to put into place that kind of, nagging afterwards to make sure that the patients don't get lost. So back to our case. So the hope is in the future that this 78-year-old man who fractures his left hip quickly gets admitted to the orthopedic service and the floor also as well with a medicine consult. He gets pre- and post-operative medications optimized. He's discharged on calcium, vitamin D, bisphosphonate, and timely PCP follow-up. So that's kind of our hope for the future. In conclusion, so I hope I've convinced you that we are in the midst of a crisis in the treatment of osteoporosis for a variety of reasons. We really need to screen women over 65 and others who are at high risk. I think we're doing pretty well, but we could still do better. And then that these medications are different. So the type of treatment, whether you treat or not, how long you treat, really has to be individualized. It depends on the patient, it depends on their risks, it depends on a variety of factors. But it's really not this blanket kind of one size fits all. And all medications are not the same. And please, if there's one thing that you take home, just don't ignore these low trauma fractures. So with that, I will conclude with some time for questions, I hope. I want to thank everyone who's worked on the geriatric hip fracture program, as well as our ambulatory health promotion program, and certainly our metabolic bone team, everyone in the clinic who's seeing our patients, and many of these folks being my mentors as well. So thank you.
question about exercise. I was wondering whether you could talk about exercise as a prevention for osteoporosis, because that's what I remember reading, and also potentially as a treatment for osteoporosis if someone develops osteoporosis.
So I hate to tell you this, but cycling is not the best. Yeah, I know you're going to be disappointed to hear that, Dr. Schwartz.
But if you fall off a bicycle and you fracture something, doesn't necessarily mean that you have osteoporosis.
No, if you're going high speed down Wolf Creek Pass and you fracture your scapula, you do not necessarily have osteoporosis. And I actually would like to have some of our researchers in the area of exercise and osteoporosis maybe chime in as well, because there's people in the audience who know this area more than I do. That being said, so weight-bearing exercise is certainly thought to be good for bones. As we talked about, osteocytes being knocked around, all of that is certainly good. And you can increase bone density, a couple of percentage points. And certainly over the course of the lifetime, we think that's really good. Again, high impact is good here. So running is really good for bone density. There are some concerns, so sports that have less weight bearing, so swimming, and there are some particular concerns about cycling that maybe some of our researchers can talk about. That there are, Wendy Court's group had some concerns about calcium loss and potentially, sweat loss of calcium. But yes, in general, weight-bearing exercise is certainly important in terms of prevention.
What about as a treatment?
What about what?
What about as a treatment?
It's hard to know. There's not great kind of randomized control data, and it's probably not enough. The conversation that I will end up having with a lot of patients who absolutely don't want to take bisphosphonates no matter what and really just want me to tell them that they can get a trainer and go to the gym and it's all going to get better, is I would say it's probably necessary but not sufficient. And I don't know if anyone from exercise research group wants to say a word.
So the benefits of exercise and fracture seem to be more related to increasing balance and muscle function overall, more so than the benefit on bone. So it's not necessarily that it's making the bone stronger, but all those ancillary portions that contribute to fracture risk are improved.
That's a really good point, and I don't think we talked probably enough about fall prevention, but certainly not falling is a key part of not fracturing, and better balance and all of that is certainly important. Bob? As people age.
I'm really surprised that you don't have a falls piece in your program. And in fact, it's ridiculous that our hospital doesn't have a falls clinic. We ask every patient who comes in here, inpatient or outpatient, whether they've fallen, and then after we find out that they have, we say, well, thank you, it's interesting to know that. And we don't do anything with those people. So I think that without question, part of this this fracture prevention program needs to be falls, because we know that with fall prevention that we can reduce fractures whether or not bone density changes.
No, that's a really good point. And there are some great materials available from the National Bone Health Alliance and all that too that we do give out in our clinic. But you're right, it's not across the board. And it's certainly something that we can talk about tying into the fracture liaison part. In the hospital, in the hospital, I believe there is some intervention, but you're right. There's a lot published out there, and even more things now on how people fall and ways to fall and different ways that can be safer.
The other point I wanted to make is that you mentioned that the bigger problem is not enough testing of the right people, not over-testing. Those aren't mutually exclusive. In fact, they can exist at the same time. And I wouldn't forget about the fact that people are still getting way too many DEXA scans probably than are necessary. And in a city where we have, maybe we still do, I don't know, Mike, if we do have more DEXA scanners than any other city per person in the world. We did at one time. I don't know if we do now. We also do more DEXA scans than any other place in the country, maybe not in the world. The last thing I wanted to mention is that you showed the fracs and you put in other things like rheumatoid arthritis and corticosteroid use, but what you didn't do is take out the DEXA number, which you can do in the FRAX.
You can, yeah.
And in fact, you take out the DEXA number, and it makes much less difference than adding age or corticosteroids or rheumatoid arthritis to that number. So the DEXA score has been known to be not terribly important for the overall FRAX score one way or the other, certainly not on the borderline.
But still, I mean, there's still certainly a correlation between bone density itself and fracture risk. And I think there are, I mean, I think a lot of the ACP guidelines show some of the older studies that really don't show much of a correlation between medications and improvement in bone density with improvement in fracture risk. But those data do exist. And there certainly do seem to be, certainly with denosumab, there is definitely a trend that the more you increase your bone density, that certainly may have a direct increase on fracture risk. But absolutely, FRAX can be done with or without a bone density. And there's certainly other measures besides, I mean, in the interest of time, I didn't talk about all of them, but there's certainly other measures, other risk factor measurements besides FRAX that can predict fracture.
Well, that was great. I wondered if you could comment on the denosumab and the new data with stopping it and higher fracture risk. And is there any consensus on what our approach should be? Do people have to then stay on it for their lives, or can we follow it with a bisphosphonate?
Yeah, I think that's a really good point. So what do you do about stopping denosumab if you know that if you stop it, there have been these rebound vertebral fractures? So there are studies up to 10 years for it now. So there are certainly people that were leaving on it longer. There have been two studies that I can tell you about. One is a very, very small subset of the FREEDOM trial where there were 6 women that got IV zoledronic acid, and it did not actually seem to really, they still lost bone. They didn't see fractures, but they still lost bone in the year following. They were given it right at that 6-month mark where they were supposed to get the next denosumab, but they got zoledronic acid instead. There's some thought in the people who wrote the article that the bone turnover markers may not be high enough yet, and that maybe if you waited a little bit longer, it would work, because there's also been some look at alendronate after denosumab, and that did actually show protection. So probably the best data we have is for oral alendronate after denosumab. It certainly seems like IV zoledronic acid should work as well, and it would be a lot more convenient to just do once a year, but we may have to look at the timing and bone turnover markers.
Karen?
Nicole, that was great. I love the fracture liaison service, and I suspect it's more important to get them on medicine right away. But I had heard initially some potential concerns by the orthopedists about being on an anti-resorptive medicine right at the time that you were trying to repair, and would it impair the fracture healing and delay union and other items such as that?
Yeah, so there have been some of those concerns. They definitely seem to be more kind of theoretical animal model concerns. There have been some studies looking at bisphosphonate use early on, and it really does not seem to be detrimental. The zoledronic acid trial that I showed you with the mortality, actually a lot of those people got their IV zoledronic acid, I believe, 3 to 6 weeks after fracture. So we do have some good data that it's not detrimental, and our orthopedic service is fine with us starting, because we've talked about that a lot, as you can imagine.
So who gets referred to the metabolic bone clinic versus taken care of by the primary care physician?
So we're really trying to put this more to primary care. So when we initially did the geriatric hip fracture program, we kind of had the metabolic bone clinic as a fallback, because not in that group it was everybody who was admitted for hip fracture, and they weren't necessarily seeing our PCPs. So we wanted to have the metabolic bone as kind of a safety net. But the hope is that, honestly, probably most of these patients wouldn't be seen in metabolic bone clinic unless there was an issue, because hopefully their osteoporosis is generally, postmenopausal osteoporosis or male osteoporosis, pretty straightforward, responsive to bisphosphonate, and wouldn't necessarily need it. So only if there's issues, I would say.
Other questions? Yeah.
My question is regarding these people that are fractured. How do you decide who gets started on bisphosphonate and who gets started on teriparatide if you don't have the DEXA right there in the hospital?
In the hospital?
Yeah, because that was the model to start them on the medication. And since the naive people to the anabolics do much better with teriparatide, where's the decision there?
Yeah, I mean, for the hip fracture patients, again, most of the hip fracture data is with bisphosphonates. And I think in that group of patients, it probably makes sense to start a bisphosphonate first to get something started, because I think we worry that what we've seen is if you do nothing and wait, then you get nothing. So the hope is generally to start those patients, the hip fracture patients, on bisphosphonate therapy. Now, the fracture liaison patients are not started by the fracture liaison. They see primary care, they get the DEXA and all of that first. So there's certainly room for that discussion. But for the hip fracture data, generally, it's thought that starting oral bisphosphonates is going to be so much better than waiting and trying something else, unless they have a reduced creatinine clearance or some reason they actually can't be on a bisphosphonate.
Mecole, thank you very much. That was great.